Welcome to the business portion of our KSAND annual conference this evening. It's my pleasure to introduce our next speaker, Cassie Whitmore, who is an RD licensed in Nebraska, and she is going to speak to us on nutrition and mental health. So Cassie has been practicing for more than 10 years. She received her bachelor's degree in public health nutrition and dietetics from Kansas State University. After starting her career in acute care and inpatient eating disorders in Kansas City, she moved on to management in a critical access hospital. However, most of her career has been spent working in long-term care at various facilities throughout the state of Nebraska, with notable experience in hospice and mental health. She also spent time as an employee wellness dietitian. She's currently self-employed as a consultant dietitian speaker. She lives in Lincoln, Nebraska with her husband, son, and dog. Please welcome Cassie to our program tonight.
Thank you. Go ahead and start here. All right, so yes, today we are speaking about nutrition and mental health, which I am particularly fond of speaking about, so hopefully you guys enjoyed as well. Here are my disclosures. Really, I just talk to a lot of organizations. So our objectives are to talk about the mental health diagnoses we may see in practice and some of their definitions, talk about some of the different nutrition challenges for people with mental health issues, and then spend some time exploring options for nutrition interventions. So a couple notes about me, like she mentioned, I've been a dietitian for over 10 years. I've worked in inpatient, outpatient, and long-term care psych. And about 20% of US adults have a mental illness, and I'm one of them. I have anxiety and depression. So I always like to mention that because sometimes we're going to talk a little bit about stigma, but sometimes people think that if you have mental illness, you cannot function at all. And talking about mental health stigma, it's estimated that a majority of people are going to have some kind of mental illness in their lifetime. Now, that's not saying that every single person is going to have long-term depression, anxiety, bipolar disorder, anything like that. What that means is that most people are going to have some experience with mental illness, but most of those people will recover, kind of like comparing having a cold to having COPD. Most people will experience a cold and get over it. Some people have COPD and are always going to have respiratory issues. And when I worked in inpatient psych, we did a training one time where they said, every person is just one traumatic event away from being placed in a psych hospital. And if you think about it, if you had a family in a car accident, you lost family to COVID, all those things can be really traumatic and could cause someone to need some psychiatric help. One study looked at mental illness in the news media, and it showed that 55% of stories talked about violence, which can increase stigma. And I always like to remind people that we really like to say, oh, so-and-so committed a crime and they have bipolar disorder, they're off their meds. But we don't often say this person committed a crime, they have diabetes and their blood sugar was X at the time of the crime. So I just like to point that out as where kind of our stigma might come from. People with severe mental illness are actually 10 times more likely to be the victims of a violent crime. And usually if someone with mental illness perpetuates violence, it's actually more likely related to a factor such as substance abuse, which if you had voices in your head telling you something and other people told you that those voices were wrong, you might also find ways to cope with that with substances. So only about 18% of the time in this study were crimes committed by someone with mental illness due to their mental illness, a hallucination, a delusion, having impulsivity. So I just like to mention that because some of you out there might say, well, obviously mental health is, health and we should talk about it. But I have talked to dietitians who say that person should stop being depressed. How can you be anxious about that without really considering that it's a disease? So just kind of a quick touch on the mental health diagnoses. I don't want to spend a lot of time beleaguering the points, but as I mentioned, a lot of the population has an anxiety disorder, almost a fifth. And some of these statistics, it's the newest ones I could find, unfortunately, but in 2017, about 7% of adults had major depressive issue. Borderline personality, that's the one that Pete Davidson talks about having, is in there. I'm not going to spend a lot of time today talking about eating disorders. I did work in eating disorders, but it's been a long time. And I feel like there's plenty of information out there for dietitians who want to learn about eating disorders. So we'll touch on it a little bit, but that's not our main goal today. I do want to mention that the schizophrenia that affects less than 1% of the population. I've lost track of how many residents I have, but at one of my facilities, I think it's about 30% of my residents have schizophrenia or schizoaffective disorder. So to me, it's a lot more common. And I wanted to touch on COVID and mental health because there's just been a lot of studies. I was preparing for this presentation. I keep seeing more and more research about how COVID's affecting mental health. So I tried to include what I could. So a couple of the studies I found, people who have a prior psychiatric diagnosis were hospitalized for COVID had a higher mortality rate than those without. Having a diagnosis of mental disorder increases risk of COVID infection, especially for African Americans and women, but the hospitalization and death rates were higher for men. And the CDC lists schizophrenia as a comorbidity that puts someone at risk for severe COVID outcomes, which is interesting. When we kind of think of severe COVID outcomes, we might think of someone who has obesity or has lung issues, but having a mental issue can be part of that as well. And then this study, it was of the Italians, who were the first country that really locked things down in 2020. And they mentioned about 17% of people had decreased appetite, 34% had increased appetite. So this huge portion of people had their appetite affected just by being in lockdown, whether that was specifically related to their mental health or not. And they said almost 50% of respondents thought they had gained weight. They didn't actually weigh them or have them be weighed, but there was this perception that they had gained weight during their lockdowns. We see increasing depression and anxiety being reported. Inpatient stays for eating disorders have increased. I saw an article recently that they said more children are experiencing eating disorders. There was a study that said about a fifth of COVID survivors had a diagnosis of a mental illness within 3 months, which you think it can be kind of traumatic. And then so many people are still having symptoms. I was just talking to someone the other day who said, oh yeah, I have vertigo after having COVID. And a CDC survey found that about 13% of respondents started or increased substances use to cope with their pandemic related stress or emotions. So, and younger people are more likely to report those issues, in part because there's kind of less stigma amongst younger people. They've been talking about it longer. Even in my own family, it's clearly generational. Every generation experiences anxiety, but my cousins and I are a lot more open about it than our moms and our grandfather. So we're seeing COVID having issues with mental health for children, adolescents, families. And in one study, respondents whose physical activity declined the most experienced the worst mental health outcomes. So all of these factors are combining to cause more mental health issues during COVID for our people. So even if your facility does not have a ton of people with mental health issues like mine does, it doesn't mean you're not going to see patients in any way, shape, or form. Like I said, I come from the long-term care world, but most of this is really applicable to any kind of practice setting. So just a couple more facts to touch on. I mentioned before that I have anxiety and depression. They often co-occur. So a lot of people have one, have both. And anxiety is the most common mental illness. And then dysthymia is a continuous long form of depression. I feel like that's what I see more in like the nursing home for elderly people as their diagnosis if they have mental illness. As far as schizophrenia, there's this idea that people with schizophrenia are always violent, that they're always homeless, that they have a split personality. That's actually dissociative identity disorder. Half of people with schizophrenia have another mental illness or other disorder, and it's one of the top 15 causes for disability worldwide, increases your risk for suicide. So it's a really scary illness for a lot of people. And severe mental illness has been found to increase the risk for death from coronary heart disease and stroke. And they think it's related in part to antipsychotic use and elevated BMI. And we're going to talk about how some of those medications are affecting the body. And this is just a really cool study I found. And if you go to the resource that I have listed, there's a lot more. This was just a fraction of them, but they had people really describe their hallucinations and what it felt like. And I thought that was really helpful if you've never talked to someone with hallucinations. So you might want to check out that study and really kind of look at some of the ones they found. Is pretty cool. So talking about how symptoms can affect nutrition. So there's this one study that showed trait anxiety, and trait anxiety is basically having that kind of generalized anxiety versus saying, I have to have a test today and I'm nervous about the test, and when the test is over, I'm fine. So people with anxiety, mostly women, had a higher BMI, had more emotional eating, ate more calories and more calories from fat at the specific buffet. And with men, their anxiety scores were correlated with the calories from fat consumed. So they had a different reaction to it. One study showed about half of people with depression have decreased appetite and a third have increased appetite. So that's a challenging part of depression, is that you're going to have a decent chunk of people who aren't going to eat as much, but then you're going to have a portion of people who are kind of stress eating. And it just kind of depends on the person. But I always remind people, if depression is the root cause of someone's poor appetite, we have to address the depression. It's come up for me and colleagues that a nurse will say, hey, well, the so-and-so is not eating. And they start listing off every other symptom. I had a gentleman a few weeks ago, and they said, oh yeah, well, he won't talk to his wife. He refused to see her on his birthday or Christmas. He refuses to get out of bed to shower. And he says he has poor appetite. And I said, well, he probably has depression, and we probably need to talk about it, because I can't really fix the appetite part if we're not going to fix the depression. We can work on it, but ultimately we have to work on the depression part. And then as far as weight changes, our medications and or disease state can affect the appetite or metabolism. That affects the weight. So switching gears to how nutrition affects mental illness, and really, if you've never read The Great Starvation Experiment, it's very interesting. But one of the very interesting parts about working in eating disorders is we see some behaviors that are, tended to always kind of be associated with, oh, that's what they do when they have an eating disorder. They'll mix foods together. They'll obsessively read cookbooks. But really what this study showed us is it's really more related to that lack of nutrition in the brain causing those behaviors versus someone having those behaviors because of an eating disorder. And one study found that obesity was associated with a 25% increase in the odds of mood and anxiety disorders. And a lot of this will say it's very chicken and the egg. We don't know which is caused by the other, unfortunately. So I mentioned we were going to talk about the medications a little bit. And this is a big piece for me when I'm working with people with mental illness, because there's a lot of medications that affect weight and appetite. And that being said, I do not go around demanding that medications are changed, but I do sometimes make mention to my psych providers about whether there's a chance to reconsider. So for example, my gentleman that I said was having a lot of issues with appetite and also depression, he was on Celexa. Celexa can possibly decrease your appetite. So I don't say directly, hey, don't you think we should put him on Remeron? But I mentioned to the provider, hey, this person is showing all these signs of depression. They're reporting a poor appetite. Their weight has come down. They happen to be on citalopram, which may cause poor appetite. Would you like to make any changes to the medications? So generally my psych providers will know that when I say that, what I mean is, hey, are they someone that would be better on a different medication, such as Seroquel or Remeron? And then my provider can make that recommendation. I never demand it by any means. I just throw it out there as, hey, is there a place to consider whether another medication will work for them? And if you don't work in mental health care, but Remeron sounds familiar, or mirtazapine, it's often used off-label as an appetite stimulant in the elderly. So I've had a number of people who are on it regardless of their mental health status. I know that not every medication on here is specific to mental illness, such as Synthroid, but I have a lot of patients on Synthroid, so it's something I consider. And I have Topamax on there because I have a decent portion of patients who are on Topamax as a form of appetite suppressant, because it can do that. So that's something just to be mindful of as well. So this can be a little, I don't think this is every single medication that can affect weight and appetite, but it's the ones I come across the most often. A few notes about medications. Again, if you're not super familiar with mental health medications, they take a pretty long time to have an effect, up to a couple months. So if you see something going on, it's a good idea to kind of look back and say, okay, well, what's been changed in the past couple of months, so you can consider everything fully. And then you can talk to the pharmacist if needed to see, is there something we can do? And that might be a helpful option, like you said, with my patients. Because I work with psych providers that know me and kind of know what I'm getting at, I can beat around the bush a little bit more easily without going outside my scope while bringing up options. But if there's something I'm really worried about, or the provider I don't work with as well, or as often, I can go to pharmacy and say, hey, I'm seeing this, or is there anything you can recommend to make a change? Also with insurance coverage, and I'm going to touch on this in a minute, but I was having kind of some trouble with multivitamins and what they had in them. And after kind of some issues with them, it looks like we've changed our multivitamin to be our standard to be a lot more, it just has a lot more stuff in it, more iron and things like that our old vitamin didn't. So sometimes pharmacy can kind of help us see if there's something we can change that will still allow us to be covered with insurance. So this is just a little, I call it the nutrition sidebar, just as a reference if you need it. I do sometimes. But the point I want to point out to you here, which is kind of a spoiler alert foreshadowing, is the vitamins and minerals we're going to talk about are found in a high variety of foods: citrus fruits, non-citrus fruits, plant foods, animal foods. So we're kind of going to talk about the whole variety of our diets. And just a note here, functional foods, dietary neurotransmitters might play a role in mental health, but more evidence is needed. So a lot of what we're going to talk about, just like anything with nutrition, we know it's really hard to say for sure eating this nutrient in this amount causes this outcome. We know that's difficult for really anything. And with mental health, it can be a little extra tricky, I think, in part because there's such a bad history with kind of abusing people with mental illness and just assuming that they don't need to have any informed consent. So that's going to be the tricky part, is it's very chicken and the egg. So when people are depressed, they're more likely to skip meals, have poor appetite, or prefer sweet foods. So it's kind of, again, like we said with the earlier statement that half people have decreased appetite and about a third have increased, same kind of thing. And there's a little bit of research to say that maybe the sweet food preference is due to trying to create like serotonin in the brain. Higher intakes of polyphenols, like in tea, cocoa, soy, etc., associated with a decreased prevalence of depression. But like I mentioned, it's chicken and the egg. It's very hard for us to say, does someone have depression, which causes them to skip meals, which means they have less variety in the diet, which means they show up as having these lower intakes or lower levels of vitamins and minerals, or does the lack of that intake cause the depression? So trying to kind of summarize the research as best we can. Like I said, there's a lot out there, and I've tried to find everything relevant I can. Really, the big thing with depression is a ton of vitamins and minerals can be associated with depression, depending on the study you're looking at. And the one I want to point out, vitamin D, which probably surprises none of us, as it's involved in so many body systems, that having a low vitamin D might be associated with depression. So if you have a person with depression, you might want to ask about their vitamin D level. But otherwise, what we really see here, I mentioned that low carb diet might affect the production of serotonin and tryptophan. And then again, we see everything from zinc and folate, which are going to come from completely different sources. So again, variety is going to be the big thing we're going to talk about. A couple things I want to mention about schizophrenia. So there's some research that shows that having low levels of folic acid, vitamin B12, and vitamin D, as well as iron, can be associated with increased schizophrenia symptoms for certain people. And the example I have to this is, so I had this patient with schizophrenia, and if we got her medications working properly and having her take them, she was great. You couldn't tell anything was different about her brain. But if she would have issues with her medications, whether that was because she wasn't comfortable taking them or they were no longer working for her, she would have a really hard time with her thought patterns. And so one example of that for me was she would call me into her room every week, every other week for a period of time, and would say, "Dietitian lady," because that's what she always called me, "I am worried about weight gain. So what can you help me with?" So we would start talking about like changes she could make to her diet. And she would say, "Well, I don't want to be restricted to my diet." And I'd say, "Oh, well, you don't have to be. You can do what you want." And she would say, "But I don't want to gain weight." And she could not wrap her head around how those thoughts were kind of in conflict. And so I got her to a point where, well, we as a team got her to a point where she was doing really well. And then suddenly she started having issues again. And so finally I kind of started digging and discovered that about 2 or 3 months before I was researching her, she had been switched from a prenatal vitamin to a multivitamin. And it was due to insurance coverage. She was on Medicaid and the prenatal wasn't covered. So I thought, well, there's a chance that if she was getting less folic acid, less iron, that maybe that's influencing her schizophrenia. So I asked to draw the levels of everything. And those levels were pending when she went to the hospital with COVID, which she died from. So I never did find out if that was the problem or not. Since then, like I said, our multivitamin actually is a lot more complete. So I don't know exactly if we changed or if that's why we changed. I was never really sure, but we did end up with, we seem to have different multivitamin now. So when I'm looking into it, I don't have as many issues as we used to. So that's just an example of something that might have been beneficial to her. With anxiety, there was a prior study that kind of mentioned anxiety, but otherwise, having at least 5 servings of fruits and vegetables per day might decrease risk. And I did want to mention ashwagandha. I almost forgot to mention ashwagandha because I'm very allergic to it. I almost let my own biases influence my presentation. But now it's becoming a lot more popular. I think even Jennifer Lopez shills ashwagandha now, but it can help with reduction of symptoms for some people. Apparently you can be allergic to it though, so just be advised. And then I did want to mention vitamin C because the 25% of adults with mental illness or substance use disorder smoke 40% of the cigarettes in the United States. So that increases your need for vitamin C. So it's something to consider as well. Okay, so just kind of starting to get into the interventions, which is probably the most beneficial part and the part I kind of want to try to spend the greatest chunk of our time on. So I mentioned testing with my one patient. Vitamin D test, usually insurance only covers certain diagnoses. So Institute of Medicine said, well, on average, most people have adequate vitamin D levels. But we live in the Midwest, we don't get as much sun. If you're talking about people who live in facilities, they have a higher rate of vitamin D deficiency. Menopausal women are noted to have a higher rate of deficiency. So I talked to my own doctor about this because I take vitamin D. And I said, do you think I should get my level drawn? And she said, anymore, everyone here is low in vitamin D. And if you might have noticed my complexion, I'm not someone who gets a lot of sunshine. So my doctor said, you know, everyone around here pretty much has a low vitamin D, and it's pretty rare for someone to end up with toxic levels. So she goes, I pretty much always put people on a vitamin D supplement, not a super high dose, but just have them take a vitamin D supplement. And I don't worry about checking levels. That being said, I work in a nursing home where I do tend to have a lot of people with low vitamin Ds, lots of reasons to check vitamin D, such as falls or having mental health issues. But some of my providers require a vitamin D draw first, which can be really challenging. I have patients who are really fearful of needles and don't want their blood drawn. And I have a particular provider who will not put them on a vitamin D supplement if they won't do a blood draw. So that can be a challenge because those people might benefit from this vitamin D supplement. So that's kind of dependent on the provider you're working with. You can also check B12 and folate. American Society for Clinical Pathology says, don't bother checking them, just put people on a supplement. In my case with my patient with schizophrenia, because she had an insurance issue, I wanted some kind of proof that her levels were low without the vitamin supplementation to help prove that she might need it, and hopefully we could get coverage for it. So it just kind of depends, but B complex supplement's pretty cheap, so that might be something that happens, or just putting people on a multivitamin. But I just wanted to let you know that asking for lab draws and vitamin supplementation can be something that can be beneficial to our patients and clients. So some ideas for nutrition interventions. As I mentioned before, we have a lot of medications that can cause weight gain. And I would say more often than not, my patients are on a weight gain causing med versus something that causes weight loss. And something came through the Nutrition Smart Brief a few weeks ago, and I think it said like 20 or 25% of Americans are on medicine that can cause weight gain or obesogenic, something like that. So there's a lot of other people out there as well that can have weight gain from their medication. So maybe this will be helpful for you as well. But so in my nursing home, one thing we do for people if they're gaining weight is we call it one portion at a time. And that was because we have a lot of our residents who have these medications on board, and they will tell me that they are just ravenous. They're like, nothing can stop me from wanting to eat. I'm just hungry all the time. So we would have people come to lunch and they would say, okay, I want the main entree, the whole side dish, everything. I'd like 2 desserts, and I'd also like 2 cheeseburgers with that. So one thing we did, both to kind of help people, partly to help maybe make a better choice, mostly to help their brain-body connection of, okay, I'm feeling full, just give them time for their stomach to tell their brain they're full, things like that. We started saying, okay, we will give you the main entree and one of your desserts. When you're finished, let us know. We'll go get you that cheeseburger. And when you're finished with that, let us know. We'll get you another one. So we're not restricting people's food intake by saying, no, you're never allowed to do that, because it's really hard to do that in a nursing home. But we are helping them slow down a little bit, which some of our residents find really helpful. We also do smaller portions to start for some people. So it's not really the traditional small portions, half portions, however you want to say it. It's more like taking the spoodle and like knocking a little bit of the vegetable off of it, just giving them a slightly smaller portion of the entree. So it's more like a 80 to 90% serving. And that helps some of our residents not really perceive that they're being restricted. And they know what they are, they talked about it, but some of them say it really kind of helps so they don't feel like it on the plate. They don't feel like they're missing out when they look across the table at their neighbor's plate. One other thing we had someone do, one of my residents, I think he has schizophrenia, I can't remember, but he was homeless before he came to us. And so he has some behaviors that they were survival mechanisms for him. And one of them is he puts a lot of sugar on all of his food. And one of my cooks came the other day and said, well, I've been doing this where he always asks for a handful of sugar packets. He's never more specific than that. So she goes, over time, I've been making that handful smaller, and he hasn't yelled at me yet. She said, is that okay? And I said, well, that's probably the best way to do it, because you're helping give his body time to adjust, his taste buds time to adjust to that lower sugar level, but you're not, and he has a lot of behaviors. So to just say you're only allowed 1 or 2 sugar packets would not work for him. He tends to become aggressive if he doesn't get what he wants. But cutting him back slowly, he doesn't really perceive that that's happening. So he's been in our facility about a year. And she says she's cut his sugar packets in half, from 16 packets per meal to 8. So I know some of you are very horrified at that right now. And I get it. He doesn't have diabetes, though. He has a working pancreas. And this is our best option to help him slowly adjust. And we know people, if they've been drinking a ton of regular soda every day, they're also getting that much sugar probably, right? But if you're drinking a ton of regular soda, and you're really used to that flavor, it's easier to kind of cut it back slowly versus just taking it all away at once. Encouraging less calorie dense foods like we would do for anyone where we say, well, maybe choose more fruits, more non-starchy vegetables, maybe choose the dessert less often, choose a smaller portion of desserts, things like that. I don't find that one to work as well for as many people, but it is an option. One thing that I definitely have to talk about a lot with my people that are concerned about their weight is beverages. And again, maybe it's associated with that whole, for some people with depression, we're going to seek out a lot of sweet foods. I have a lot of people who drink a lot of chocolate milk, a lot of regular soda, things like that. So we do offer a number of sugar-free beverages, but we still have a pop machine. They're still able to go purchase a pop if they want. And we actually buy the pre-chocolated chocolate milk because we go through so much. So something I've said for people who are having issues with weight gain is maybe we say, okay, here's your chocolate milk, and it's half the regular pre-chocolated milk. And then we pour the half the glass as white milk. And that way we're kind of still giving them a pleasurable experience that still tastes like chocolate. But again, we're kind of changing it over time. Maybe go from 3/4 chocolate milk and 1/4 plain to half and half, and just kind of help them adjust their taste buds again as well. And that only works as long as the residents are okay with it. So that's why I said with my gentleman with the sugar packets, I said if he gets to a point where he's upset about it, then we kind of have to maybe go back up a packet just to let him have some time to adjust. We might need to reconsider our snack carts, our nourishment stations, what we have. You know, it kind of depends. If you have a lot of people who have mental illness who are really hungry all the time, maybe you have to say, okay, do we have healthy options available for snacks? That was something for a long time. Our snack cart was very focused on kind of the chips and cookies and things like that. So we've had to adjust over time, and we do put money into buying the pre-bagged sliced apples, baby carrots, cheese sticks, things like that. And we actually put even a fridge at our nurse's station, a little one, so that they can have those kinds of snacks available, because we found if they were easy to eat, our residents took them better versus just putting whole apples on the cart, things like that. Maybe if you, like I said, in the nursing home, we have a lot of activities. If someone is at home with a mental illness, how are their activities associated with food? You know, is every single time they're getting together with friends all about food? We might need to consider what that looks like. And then you might have to talk about an appetite suppressant for some people. I don't usually bring it up to my residents. If they are asking about appetite suppressant, I will ask the question, but I don't usually bring it up. Sometimes when I mention to a provider that someone's having issues, they will go ahead and start a suppressant on their own. Now, as far as weight loss, I feel like we all tend to be a little bit more familiar with what to do if someone's losing weight. We can put a supplement on board, we can offer them snacks, we can alter their food by adding more butter to their mashed potatoes or whatever. In the case of people with mental illness, talking about those med changes, like I said, for some people, maybe they're appropriate to switch from a med that depresses their appetite to one that stimulates their appetite. And then encouraging them to eat with others, because we know that that is helpful towards having people eat more. So that's been a challenge with the pandemic as well, whether it's because someone is in a nursing home, but they've been having to be in their rooms, or like people with eating disorders having supportive meals. That's been challenging. So I know I heard someone recommend have people do supportive meals via Zoom, have them get on a video call with someone to eat with them together to help kind of with that balance. So one of the things I have challenges with as well is some of my patients who have paranoia with food. They're worried, did this person alter my food in a bad way? Did, one of my patients has schizoaffective disorder, and a big issue for her is thinking, she drinks a lot of supplements. That's her preference. They have to be given to her in that box so she can see that they're not damaged in any way. And one time she said there was a whole case that came in and it had been damaged. And she goes, well, I was pretty sure that the delivery guy was trying to kill me. And to her, that was a perfectly logical statement. And so I had to reassure her, oh, no, we're having shipment issues. We'll make sure we get some more in that's not damaged. But that's something for her, is having that come in the package so she can assess it, helps her feel more comfortable. And for some of the people, having a less varied diet is going to be the way they go down. I've mentioned having that diet variety can be helpful, but if someone's so worried about it, it might not be worth going down that path. And we might have to have them on a multivitamin. And maybe they do just need to eat prepackaged foods if that's something they're okay with. Maybe they need to know that going and getting fresh fruits and vegetables from the store is not an option because they feel worried people touched it. So maybe if they have the meal that comes and it's sealed, that's more comfortable for them. So maybe helping them figure out what are those prepackaged foods that would be the most beneficial to me without influencing my nutrition in a negative way. So kind of touching on all those different studies, most patients could probably benefit by having more diet variety. And we know that's probably true of many of our patients. But again, depending on diagnosis, it may or may not be doable. When I did work in eating disorders, I had a patient with schizophrenia, and the psychiatrist said, everyone else here, I really want you to push the variety. For this person, that's not going to be the right choice. They're never going to get to a place where having something different every day is going to work for them. So how do we go ahead and help them work around that? But one thing to consider, especially if you're working with people cooking for themselves or in a facility that's cooking for a lot of people with mental health issues, is how is that food being prepared? One thing we found that was kind of a bummer was that for a long time we'd had trouble keeping great staff in our kitchen. And that meant that the food coming out of our kitchen was not always as good as we would have liked it to be. And the other day we were talking about how our cook was sauteing the zucchini, which is what the recipe and the menu said to do. But our prior staff had just been kind of saying, oh, we have a vegetable, let's boil it for 2 hours and see what happens. So all of the vegetables we served would tend to be a bad texture, ugly color, weren't flavorful, so people wouldn't eat them. Surprise, surprise. So considering for us, okay, are we preparing our foods in a better way? If we've prepared an item and our residents hate it, is there a different way we could prepare that item that they would actually like it so they get that variety in their diet? Same thing for people who are at home cooking for themselves or having other people cook for them. We know for kids, they might have to be exposed to a food, 10 or 12 times before they accept it. And part of that is we're going to encourage, okay, well, try, if you don't like broccoli steamed, do you like it sauteed? Do you like it roasted? Do you like it raw with dip? Do you like it with cheese? Giving them options. So considering that as well, are there different ways people could prep their fruits and vegetables to get that variety? Same thing with other foods to make sure they're more pleasurable. Just to touch on mindfulness, a lot of us are pretty familiar with the topic, but there is some research that says increased mindfulness might reduce emotional eating. So if you're comfortable with it, if you feel that you have that skill, you can try doing mindfulness exercises or encouraging your patients to do mindfulness exercise, such as, being really mindful when doing the dishes. Let's just focus on exactly what I'm doing while doing the dishes, or eating an item with all of your senses. Let's really talk about how does this grape smell and taste, and what's the texture, and what feelings does it evoke for me? That can be helpful if someone's really struggling with that part. So a few other notes. Diet education is an option, but the patient has to be agreeable. And I will say, I find that sometimes my patients will really have decided they really want to talk to me about their nutrition, and they're really interested in speaking to me about it. And there are other times when they're definitely not. And I think sometimes my doctors will kind of insinuate that I should be more aggressive. And I just don't find that approach works. I really work hard to build rapport. So I have a gentleman who has drank 3 regular Cokes every day for as long as I've known him. It's like 3.5 years. And every 18 months or so, I go to him and I'm like, hey, I should probably talk to you about all your soda you're drinking. Do you want to try drinking diet soda? Do you want to try cutting back? And last time he said, well, I used to drink 6 and I cut it down to 3. And I said, all right, cool. I said, as your dietitian, I'm always going to encourage you to choose more water than soda, but I understand this is your choice. So if you want to talk about it more, let me know. But I do find that I have to kind of have a little bit of a light touch. I can't be overly aggressive and stuff with my patients. And like I said, I'm sure that makes some of my doctors very angry at me. Again, encouraging that diet balance as able, as appropriate, trying to see, well, where could we encourage more diet balance that this person would be okay with it? Encouraging that more. Where can we incorporate more fruits? Maybe even just encouraging fruit-based desserts. If someone really likes sweets, oh, could you do apple pie instead of chocolate pie? Could you make a pear crisp instead of making cookies? Things like that. And whole grains as well, vegetables. And meet people where they are. I try to remind people of that as well. A couple other notes, because I have so many patients who've had that weight gain due to their medications, I often have people on protein powders, liquid protein supplements. If they have any wounds, we have a lot of people with like weeping skin. We have to consider that for. But I always want to remind people, you have the right to make choices, even if they're bad ones. This comes up a lot in the nursing home. If you don't work in nursing homes, a lot of what we talk about is resident rights. And so many times I have a family who says, well, I have POA, so I get to tell you that you're not allowed to give them a second piece of cake. And I'll say, people have the right to make choices. Even if they're not allowed to make their own medical decisions, it doesn't mean they can't decide what to have for lunch. So I can go educate that person, but that doesn't mean that they're going to make the choice you want them to. And so I have a lot of patients who smoke. We let them smoke. We don't restrict that from them because they don't have a lot of other things going on in their world. And telling them, well, you're not allowed to smoke. You can't do any of these things because you have mental illness and we're going to say you have no right to make choices. We don't feel like that's appropriate. So a few notes on physical activity research. One study showed that for people with severe mental illness, having increased sedentary time and decreased moderate or vigorous activity time increased their risk of cardiovascular disease. So encouraging activity might be helpful if appropriate. For people with depression, resistance exercise may reduce symptoms, and moderate intensity exercise can help improve mood for some people. And physical activity is thought to protect against anxiety symptoms and disorders. And I will say, as someone with anxiety and depression, regular exercise is very important for me to manage my depressive symptoms, and it can help me manage my anxiety, not as much as it helps with the depression, but exercise, some cardio is very important to me for that reason. So just a couple notes about notification. Important to coordinate with other providers, especially if you are in an outpatient setting, or even if someone comes into a hospital and you're not exactly sure what does everybody know about. Sometimes someone will tell the dietitian something that they won't tell anyone else, or you'll come across some interesting statement. But I always will say it's better to call someone and say, hey, did you know about X, Y, or Z with our patient? Or, and then they, oh yeah, I definitely did, rather than assume they know and find out, oh, they didn't know that. And they're making a decision based on inadequate information. And if you work in eating disorders, you have to be in touch with a therapist and psychiatrist to figure all of that out together. Just like anything else, it's good to do individualized care. Like I said, we have to get the patient's opinion whenever we can. I do have a number of patients who have such strong mental illness that I can't always communicate with them. Sometimes I'm not able to communicate with them at all. So sometimes what I just do is I'll try something and then we see how it goes. And just see, did they enjoy this item that we gave them? Did it work for them? How did that actually look if they can't communicate with me? I always try to check back. Is this working? Is it not working? Try to talk to my nurses. They usually know a lot to tell me. But meal intakes might not be the full picture. Some people prefer to snack. versus eating meals. I have a lot of people who keep a lot of snacks in their room, so their meal intakes are terrible, but their weight is stable. And if you ask nursing, they'll say, oh, they got so many snacks in the room, don't even worry. And as I mentioned, some people prefer liquid supplements instead of eating. I also have people who will demand that I keep them on a PRN supplement, even though they never drink it, just because they want it as the option. So just a couple notes. I always say, put yourself in their shoes. If you're not someone who has mental illness, if you haven't worked with it much, like I said, I've talked to dietitians who will say that person should just stop being depressed. And I'm like, well, you probably haven't met anybody who was very clinically depressed before. My patient who had schizophrenia and died of COVID, on her, before she went to the hospital, she was convinced that she was pregnant with triplets. And every person would say, oh, no, you're not pregnant with triplets. Don't worry, because she was always very worried she was about to go into labor. But she was intubated before she died. And I have to imagine it was a very scary feeling for her to continue to say, I think I'm pregnant with triplets and everyone else tells me I'm wrong. So I can't even believe my own brain. So I try to, when I've had cooks and staff who are just really not understanding, I try to remind them, just think of what it would be like if everyone told you couldn't trust what your brain is telling you. That would be very scary. Be aware of triggering language. Again, with people with eating disorders, we like to avoid talking about their weight. My patient with schizophrenia that I've mentioned before, she talked to me a lot. She really liked talking to me. When they first went on COVID lockdown, she waved me down the hall and I said, what you need? And she goes, oh, I just wanted to chat. Everything's fine. So I do miss her. But she always told me, if I as a habit, I tend to say, oh, I'll keep an eye on you. And she said, I don't want you to keep an eye on me. So we talked about, okay, what would be comfortable? And she said, oh, well, if you said, I'm here if you need me, that feels better. I said, okay, perfect. I'm here if you need me. So just kind of being mindful of that for people. I would say it's up to therapy or psychiatry to determine which behavior should be challenged. I have a patient that appears to have binge eating disorder, but I haven't had anyone diagnose her with it yet, despite asking about it. So I cannot treat her like a patient with binge eating disorder without that diagnosis. It's not up to me to say we should take snacks out of her room. Now, that being said, they have put restrictions in the kitchen about what things they will heat up for her or how often they would, because she will get large amounts of food. She wants the kitchen to heat up for her instead of eating and she will eat what's in the dining room too. So we kind of have to work about that as a team. And one study showed that Gen Z members are more likely to report their mental health as fair or poor and more likely to have received treatment from a mental health professional. Like I mentioned, it's just kind of becoming less stigmatized as we go on, which I think is really good. A couple of resources for you that aren't listed in the actual references section. Some notes about stigmatizing language if you're not sure. And also an article about phrases to avoid if you work in a helping profession. And I have a TikTok video from an animator who has schizophrenia, and he animated what his schizophrenia feels like. And I thought that was very interesting if you are kind of unsure what that looks like for someone. And then I always like to end just mentioning it's important that you take care of yourself too. 67% of healthcare workers screened positive for burnout in a pandemic study. You can't take care of your patients if you aren't taking care of yourself. So kind of figure out what are your benchmarks for yourself. I know if I'm not thinking of new ideas when I'm on those long country drives going to work, that means that I'm a little too stressed out and I need to figure out what to do. So write all your best coping mechanisms down. Sometimes if you're really overwhelmed, you kind of forget, you know what, it really helps me if I go for a walk outside or if I call my friend or whatever. And you can write down even what are my signs of stress? Like I said, if I know if I'm not thinking new ideas, okay, I need to take a minute. Consider taking a mental health day if you need it. That's important too. And be forgiving of yourself. A lot of us have been under a lot of stress for a long time. So does anybody have any questions?
Well, thank you so much for that amazing presentation. I know Becky's getting us pinned on the screen, so that way you can see myself and Cassie here. There we go. And I didn't mention it at the top. If you have any questions, put them in the chat below and I'm more than happy to share them. That was an amazing presentation. Thank you so much.
Thank you.
Especially because May is Mental Health Awareness Month. So
Yes.
right on with the topic, which we didn't even think about when we asked you to speak, but we'll pretend we had it planned all along.
That's right. It was always in the plan.
So far, we have everyone just saying great presentation. I'll ask
Thank
you a
you,
question that I had. You talked about at the end that Gen Z is becoming more open about mental illness or treatment for mental illness. Do you see, as the generations get older and obviously transition into more medical care, how that might change discussions or treatment or openness of both the patient and the practitioner, how that's going to be changed?
Yeah, I think it's really interesting because so many of the older generations are just really uncomfortable. It's never been an okay thing to talk about. And, like all the women in my family clearly have anxiety, but the older women in the family will say, oh, I just get nervous. And then the rest of us are like, we have anxiety and it's a disorder and that's what we deal with. So I think as our providers become more comfortable asking those questions and treating mental illness just like anything else, that makes it more comfortable for our patients to say, yeah, this has been bothering me, or my mood isn't what I feel like it should be, or these situations are more stressful to me than I thought they should be. So I think the more everyone's open about it and talks about it and normalizes it, the better it is for everyone else. So I think we're going to see more and more patients come in with mental health issues, and we're going to have to deal with it more and more as we go on.
Absolutely. All right, we got some questions coming in. So from Lindsay, we have excellent presentation. You didn't mention it, but what about ADHD and OCD?
Good question. So I don't work a lot with patients with ADHD, and if they do have it, it's not their primary, so it's not something we necessarily deal with. So that's not my strength, to be quite honest. As far as OCD, most of my patients right now who have OCD also have schizophrenia, so they kind of blur sometimes. Just like anxiety and depression are kind of hard to suss out which is causing which. Same thing with OCD and schizophrenia for some of my patients. I did have one gal with OCD who actually discharged to a lower level of care. It was very exciting after years and years with us. So I don't deal with it quite as much on its own. It does associate a lot with eating disorders though too. So a lot of people with eating disorders will have OCD as well.
Excellent. Claudia asked, are you seeing an increase in younger patients with mental health issues, or that you see?
Yeah, the population I primarily deal with is fairly young as it is. And I think I see, because I work in long-term care, I don't probably see as many young people as maybe outpatient. But I will say among our staff, it's become more, we notice our staff is a lot more open about it, and open about saying like, I just need to take a mental health day today. My brain's not cooperating with me, or being really open, like, I have an anxiety disorder and this is a situation that bothers me, things like that. So I'm seeing it just in my staff that they're being more open about it. And then the pandemic has kind of accelerated all of it, I feel like.
I think it put a spotlight on many, many things. And I think that was definitely one of them.
Yes.
We have from Janine, what would you suggest to a new RD interested in this field? Any books, career moves, or any information that you have?
There is a DBG for behavioral health. They have a lot of resources. I think it's just behavioral health DPG. So that might be a place to start. I really like the menu Serve for Science. That's a good look at we weren't even looking at mental health issues back then. It's just an interesting book. But there's a lot more out there. And I think maybe one of the most important things as a provider, if you haven't had a lot of experience with people with mental health issues, just learning what that looks like for other people. There's a lot of books out there written by people with some form of mental illness, any kind of it, that really helps you understand how people's brains work. So if you're not familiar with what PTSD or schizophrenia looks like, that can be helpful to just get a picture of how to empathize with someone else, which I think helps your practice a lot.
Excellent. And she also asked any career moves. So anything you did, as you were training or, change in positions that you felt helped or maybe didn't help that you wish you had.
Oh, perfect. Sorry, I missed the second part of that question.
That's okay.
Yeah, so I kind of, when I started my career, fell into being a PRN for inpatient psych, and then became the eating disorder dietitian. So I kind of, to be quite honest, fell into it and then fell in love with it. And what I've found is along the way, just being a little bit more open to opportunities. My facility that's primarily mental health issues was considered by some of the dietitians in the region to be like, oh, you don't want to go there. It's where the crazies live, and I was like, I'm just gonna consider it my own way, not consider what you're thinking about it. And it really helped me because I love it. So I think just being open to the opportunities that are out there and throwing your name in the hat a few times when it comes up on a listserv or something can be helpful.
Excellent. We have, Janine says, thank you.
Thank you.
We have from Heidi Wells. She says, my husband's family has a history of mental illness. He started noticing signs within himself and started going to counseling. It's been great for him. So glad you included the chart on physical activity and mental health. He's a farmer, and during his busy seasons, it's very physically demanding, and he tends to manage symptoms more during the slower season. Is that something you see, especially being in Kansas? I know we have farmers and a lot of that. Do you see any of that with any of your patients?
Yeah, it's really interesting. Sometimes, like personally, over the years, we've kind of figured out that like my depression is seasonal affective disorder. So my depression is much worse in the winter when it's dark. And, so we kind of, it takes time sometimes to notice when people are having symptoms. And so noticing like, oh, when it starts getting cold in the winter and it's not as sunny, I need to get some sunshine time in extra because or even use a light to help me have a little bit less depression than I would otherwise. So I think that can be tricky. And, sometimes we have people like journal what their symptoms are and what's going on. Is it situational, something happened at work, or is it seasonal, or it's a rainy day and that bums me out, kind of a thing.
Excellent. Lindsay had another question. There's been a surge of obesity during the pandemic. What would you say to the standalone RD that feels this is related to a mental health issue versus just food choices?
A lot of mental health issues are associated with weight. I think when we just excuse any problem we have as being, it's just a mental health issue, that's minimizing the things that are going on. And we have to remember that we do the things we do because they help in the moment. Eating as a coping mechanism works because of serotonin and tryptophan, and our brain is designed to say, oh, this is great, this is awesome. And that works fine if my, stressful situation lasts a day or two. It's not, our bodies are designed to chase after a buffalo and then chill. And that the pandemic has been the opposite of chase after a buffalo real quick and then chill. So, our bodies are designed to behave in a different way. And I think just respecting that and trying to see that as a sign, okay, for my body, if I'm gaining weight in a period of time, that usually means my body's stressed out. So how do I help my body? How do I see that as my body sending me an alarm signal to help my brain, and how can I manage that better? So I think looking at it that way, that it's your body saying, I need some help. This isn't working. How do we make it work better?
Absolutely. We had a comment from Lynn. She said, I'm part of a generation that was silent on mental illness. I'm just now being able to take the info in and educate myself what I need for my WIC clients. Thank you for this evening. So I think we have a lot of people, whether it's family or personal or patients. I think COVID highlighted it, but it was there before and really, really brought a lot to light. Lindsay also says, thank you. If you have more questions, put them in the chat. If not, I have a list, so I'll go to my own. one thing I wrote down, you had a lot of great charts of medications, and that's something I feel with any disease state, medications just get overwhelming. Do you have a reference that you tend to go to, or anything that you use to keep up to date, especially those that affect appetite? Because I feel like everything nowadays gets listed, appetite, weight gain, or weight loss is in there somewhere, that you kind of use as a reference source.
Yeah, and I literally was just watching a commercial the other day for mental health med, and I within the course of a week saw this commercial twice. And the first time they said, this med is not shown to cause weight gain. And the next time I saw it, it said, for some people, this medication causes weight gain. So like, even after having it a while, they figured it out. So really, this is probably maybe not a good dietitian answer. Whenever I come across a med that one of my patients starts, because a lot of them, because they've had mental illness for so long, sometimes those meds don't work, just like with any disease. So they'll start the newer ones. So I Google it when I don't know what it is. And Mayo Clinic, National Alliance on Mental Illness, and National Institutes of Health are all really good websites that will tell you, basically just Google the med and it'll tell you the side effects and if there's anything else major that you're supposed to know about them. So usually that's how I do it, as I hear about them, and as I or if I see something on TV, I might even look it up and say, okay, is this something? Put it in the back of my mind for when a patient starts it. And sometimes I will Google things multiple times because I'll be like, did I look that one up? Did I know it? So yes, Google's my friend. I use it a lot, but I try to stick to the appropriate websites, and National Alliance on Mental Illness, Mayo Clinic, and National Institutes of Health have all been really helpful to me.
I appreciate that. I think we've all been to the Google a few times to go, what is that?
I don't know how you guys did it before there was Google.
Right? Or you don't know it, but then you realize that either the generic name and it pops up and you're like, oh, I know the med. I just didn't know it as X, Y, or Z.
Exactly.
Oh, and that Google can help with that too. Does anyone else have any other questions or comments for tonight? I'll give you just a second. Lindsay had another comment. I know some of these medications have other nutrient ramifications, such as Topamax and sodium. Is that something you check on any schedule?
Any of my medications that really seem to have any effects with any potential labs, my pharmacist and my providers stay really on top of, so I don't have to. We even have a few meds where, they're like, should check their B12 levels and stuff, and I never have to ask for them. They're always done. So in my particular, when I have primarily patients with mental illness, everyone is kind of all tuned to it. So like I said, pharmacy is really aware, and my providers are too. And we have both physical and mental health providers in my facility. That being said, I have a different facility that's primarily very aged people, and I just admitted someone there with schizophrenia 2 weeks ago. So I will probably have to pay more attention for her because it's not as well known there. But I really use my resources of the rest of the team because we all will remember bits and pieces of the things that are most important in our orbit, and then we learn from each other that way as well.
Excellent. So far, no other questions up here. I had one other one for you. You talked about, I liked the idea of one portion at a time, not limiting if they wanted 2 hamburgers, but you got to eat the first one. Is that something you implemented just as a general rule for the kitchen, or does it apply specifically if you put it in a diet order as a diet restriction?
It's generally just kind of our policy. And it started just because we have so many people that experience this issue. It was just becoming a big problem where everyone was wanting 6 hamburger, we're trying to make a ton of hamburgers all at the same time. And so it started out as kind of like just a staffing problem that was related to the mental health problems in our facility. And so we kind of instituted it as a blanket rule. There are some people that we don't follow that for if they have a particular reason. So it just kind of depends, but it's kind of our default at this point.
I think it's a fair default. That way it's easy to not signal people out.
Right. And then we always make sure we have enough for everybody, and which was also kind of our main goal.
Gotcha. All right. Well, I don't see any other comments or questions in the chat. Do you have any other final words of wisdom or thoughts or anything as far as your position or mental health and nutrition, anything like that.
Well, I just want to thank you guys for having me. Kansas always has a special place in my heart. And, I appreciate you guys wanting to learn more about this topic. It's also very close to my heart. So I very much appreciate it. And feel free to email me later if you have questions you come up with or thoughts or ideas. And that's how we learn best from each other, is we try things and we see this worked for me or this didn't work for me. And I think that's how we just become better as a profession.
Absolutely. Well, we thank you so much for being here. As I said, especially being Mental Health Awareness Month, it all lined up, and we appreciate you sharing your knowledge. It is helpful to hear from everybody. We always learn as we grow from others. So we appreciate your presentation tonight. I appreciate everyone who's able to join us live. This is recorded, so we will be able to post it. We do have approval for CEU, so we will be getting that out to you shortly. We will be sending out the slides along with your certificates as we get them. Becky and I are going to work in the next, hopefully, day to have these posted as far as recordings. And as your current KSAND president and kind of our last interaction before my end of the year, I just want to say thank you for an amazing year. I hope some of you consider getting on the board after today. If you're not, or if you have any questions, feel free to reach out. We're happy to talk honestly what this all takes and what it is. But we always appreciate your membership and support. We appreciate you all being here tonight. So have a lovely Wednesday evening, and thank you so much for joining us.